about mainly a background about the NGS-MRD assay and comparison between flow and NGS-MRD, and then the technology of graft TCR alpha-beta depletion and its use in transplantation, and then the results of our own trial, which is the ONC1401, and I'm going to focus on ALL patient, showing an interim analysis for a repeat precursor ALL patient with respect to MRD. And then I'm going to talk briefly about the role of transplantation in the era of CAR T-cell therapy, although my colleague in the first presentation have went into the details of this. I probably could skip some slides in this area. And then briefly I'm going to touch on the summary of ongoing research and future directions. So this is basically the B and T cell surface immune receptors, and you could see the IGH or the B cell receptor is compromised of region, variable region, the D region and the J region. The same for the TCR. The reason I'm pointing to this because this is essential into understanding and developing the technology of NGS MRD for detection of residual disease in B precursor ALL. I want to bring to your attention into the antigen receptor, which are assembled by the VDG recombination, and I want you to focus specifically into an area called CDR3 region, which is basically receptor protein genes. When the VDG recombination generate a unique receptor DNA sequence, which can be used to identify single or B or T cell receptor. This CDR3 region is highly diverse, and it's the key in determination of the receptor antigen specificity. And you could clearly see here, you could limit that to a certain gene, which are the variable genes and the diversity gene, and then the joint gene between the two variables and the diversity gene. And this concept of diversity that's introduced at the junction by the insertion and the deletion of the random nucleotide that allow basically the generation of the unique CDR3 region that's used for tracking of the residual disease or the cell of origin across the various stages of development. It notes that for the people who do lab research or the clinical pathology group, that unlike what's always taught about this type of assay, the depth of coverage is actually only 10x, where most of the people who thought it have a much higher depth of coverage, and basically the length of the segment amplified is between 100 to 150 base pair, make it basically a highly applicable or less sophisticated than what's thought by people who look at this for the first look without specific knowledge of the methodology used for this. So the NGS-MRD assay identify the dominant sequence associated with malignant lymphocytes. So simply, the malignant T or B cells are mixed with the normal cells, and you basically extract the DNA and you look for the DNA sequence about the specific dominant sequence, and you would use that sequence to track the residual disease across various stages of treatment. Basically, the main advantage of this platform, it generates an MRD results that are direct measure of the tumor and not a surrogate of a response. In most of the country, in the US, in most of the centers, and also in most of the countries outside Europe, the summary, the standard of care for detection of residual disease is flow cytometry. I want to give you an idea what's the difference between the standard flow assay and the NGS-MRD assay. The most remarkable difference is basically the sensitivity, which is 10 to the power of 4 with flow cytometry. It can go up to the 10 to the power of 7 with the NGS. The informative clone is usually up to 95% of cases, similar to multi-parameter flow cytometry. One of the main advantages of flow cytometry that you do not need a pre-treatment baseline sample, although it's preferred, but it's not essential. However, in utilizing the NGS-MRD technology, it's essential to have a baseline blast sample to identify the dominant clone so you are able to track it. Both of the methods use universal reagents, and the turnaround time obviously is much faster with multi-parameter flow cytometry compared to NGS. The next background that I want to talk about is graft manipulation. Our ultimate goal as a transplanter is no GVHD and to promote the graft versus leukemia effect, and we think that can be achieved through TCR alpha beta depletion and across the different HLA barriers using haploidentical transplantation. So I'm going to briefly discuss this concept before going into the actual results. So briefly, the TCR gamma delta T cells are the non-conventional T cells, that they are innate-like T cells, and they circulate, represent 1 to 5% of circulating lymphocytes. And activated gamma delta T cells can kill pathogens by production of bacteriostatic or lytic molecules. The most important thing, as established in literature before, they do not cause graft versus host disease. However, they do maintain graft versus leukemia effect, as evidenced by this publication, which was published as early as 1996, where it shows that the rate or the proportion of gamma delta T cells in peripheral blood early post-transplant is strongly associated with the risk for relapse. NK cells are an important component of the innate immunity. I think we should blood this, otherwise it's going to collapse. So if you could obtain the power source, because it's going to stop in a couple of minutes. So NK cells are the important component of the innate immunity, and they basically limit or eradicate pathogens during early phases of infection. And alloreactive NK cells have GVL effect, and the NK-mediated GVL effect is completely separated from the graft versus host disease. So in summary, NK cells could promote graft versus leukemia effect, but at the same time avoid the graft versus host disease. A common problem that we find as a transplanter is donor selection and finding a suitable donor matched or an unrelated donor. If we prioritize donor selection on the basis of care disparity, where basically alloreactive NK cells will have the potential to improve the outcome of care mismatched transplant, which means decrease the relapse risk and decrease the infection risk. If you use a matched sibling donor, it's unlikely unless there is an HLA recombination. If you use an unrelated donor to find a care mismatched donor, you would have an HLA-C mismatch, which carry a higher risk for graft versus host disease and graft rejection. If you use a haploidentical transplant, the possibility of GVHD is maximal, but that could be eliminated using T-cell depletion and aggressive immunotherapy and increasing the dose of stem cells. However, your chance of finding a care favorable or a care mismatched donor to improve care alloreactivity is the highest. If you do a TCR alpha beta with CD19 depletion, the main advantage of this approach for the graft, there is no immunosuppressive therapy post-transplantation. Basically, you eliminated the graft versus host disease effect or possibility, which basically means you are able. There is no need for immunosuppression post-transplantation, and you do not need to maintain patients on immunosuppression or cyclosporin or any immune or drug level monitoring post-transplantation. So the highest chance for care mismatched donor with a haplotransplantation, which means the highest chance for graft versus leukemia effect, lower chances for post-transplant infectious complication, which means faster immune recovery, since you do not use immunosuppression, and at the same time you are keeping the specialized gamma delta T cells that cause graft versus leukemia effect but avoid graft versus host disease. And the most important factor is donor availability across HLA barriers. Since most of the patients would have one of the siblings who's a half match, or at least one of the parents could be used, which is usually a half match. So this is basically the principle of TCR alpha beta depletion, where we would use magnetic bead that would basically attach to the alpha beta T cells, and then you do negative selection for the alpha beta T cells, and what's left is the gamma delta T cells and the NK cells and the CD34 positive cells that would be used for your graft. So I'm going to focus on our trial, which is a PBMTC trial, ONC1401, and this included several other arms of several other diagnoses, so I'm going to focus on the results for ALL patients. This is a multi-center trial that had 11 participating centers, and it did have 3 cohorts. First one is the care biology cohort, which allowed any donor or any cord blood graft. Then the descriptive cohort, which is basically the non-care favorable haplo, but those patients underwent TCR alpha beta depletion as a source of the graft. And then the phase 2 trial, which allowed only patients who had care favorable graft that was TCR alpha beta depleted too, and using one of the study conditioning regimen. So the interim analysis objective, which I'm presenting, is basically to evaluate if NGS-MRD predicts outcome and post-transplant NGS-MRD for ALL patients, and analysis of the relevant clinical factor to assess the relationship to event-free survival. This is summary of the patient's demographic, and this analysis includes 57 patients with median follow-up of 523 days post-transplantation. You could see the majority of the patients were B-cell ALL, and basically most of the patients were ALL in CR2. And if you look here, all donor grafts are allowed, bone marrow or cord blood or peripheral blood. There was only one graft failure, and patients were split between a TBI-based regimen versus a non-TBI-based regimen. This is summary of the NGS-MRD baseline identification. Basically, this is the question we are asking: can we identify a clone that's suitable for tracking for NGS after this through different phases of treatment? And you could see here, in 100% of B-cell ALL patients, we were able to use B-cell receptor rearrangement to identify a trackable clone, except in 2 cases where we had to use TCR-G as to identify a clone that's trackable. But in summary, 100% of the patients were able to use that technology to follow up MRD. When we applied the same concept to T-cell ALL with a limited number of patients, we were only able to track this in about 2/3 of the patients, or about 66% of the patients, using TCR-G or TCR-B. Of note here, although we are looking for B-cell ALL for B-cell receptor rearrangement for trackable sequence, since the change in the clone occur at basically at earlier progenitors or common lymphoid progenitor, or the level of the stem cells, before even they differentiate into B or T cell progenitors, you could use T cell receptor rearrangement even you are looking at B precursor ALL leukemia. Obviously, patients proceed to transplantation only if they were in morphological remission. In this cohort, pre-transplant MRD assessment in bone marrow, 10% of the samples were positive by flow cytometry, but 35% were positive by NGS technology. Here, if we look at the pre-transplant NGS MRD from the bone marrow, it was highly predictive of event-free survival, where almost all the patients who were NGS MRD negative survived, compared to basically approximately only 50% or slightly less than 50% of patients who were positive survived during the follow-up period. There was no detected benefit of graft versus host disease in NGS MRD negative patients. If you look at the 2 top lines, which represent patients who were NGS MRD negative and no GVHD, or NGS MRD negative and had GVHD, the 2 lines are superimposed, indicating the disease-free survival was 100% on both benefit and inferring there was no benefit from graft versus host disease, at least in this cohort. If we compare basically the TCR alpha beta depleted haplotransplant versus other stem cell sources who did not, or are either unmanipulated bone marrow, peripheral blood, or cord blood, there was no difference. And you could see that the numbers are split equally, and the probability of event-free survival is almost superimposed. The only difference, there was a decreased incidence of GVHD with haplograft, with only 1 patient developed acute graft versus host disease more than grade 2 and went to develop extensive chronic graft versus host disease. If we look into the conditioning regimen, and the conditioning regimen varied between TBI and non-TBI regimen, reduced toxicity or reduced intensity regimen, you could see here that the probability of event-free survival was almost similar regardless of the preparative regimen, whether you use a myeloablative conditioning or a reduced intensity conditioning, and there was no difference whether you used TBI versus non-TBI conditioning regimen. Of note that the transplant-related mortality was very low, approximately 5 patients of this population, and most of them were able to be rescued if they relapsed after this with CAR T-cell therapy or immunotherapy with blinatumomab or with inotuzumab. We went after this to study the interaction between obesity using pre-transplant body mass index based on weight and height at the time of transplantation in the context of NGS-MRD and study the effect of this on event-free survival. We divided subjects based on BMI score derived from weight and height at the time of transplantation into lean, overweight, and obese patient, and this is basically derived based on the CDC published guidelines for classifying patients whether lean or obese or overweight. You could clearly see here that lean patient had better overall survival than overweight or obese patient, representing the top line, and there is an incremental drop in the probability of event-free survival with weight gain. So basically, lean patient did best, and with basically an advancement in the weight category, your event-free survival dropped significantly. If we look at the event-free survival by weight category and NGS-MRD, you could clearly see here that lean patients who were NGS-MRD negative fared the better or the best event-free survival, 100% in this case, and there is an incremental drop in the event-free survival with the NGS-MRD positivity and with the increase in the weight category with the patients who were obese and MRD positive, none of them survived, and patients who were NGS-MRD positive and lean had almost close survival to patients who were NGS-MRD negative and obese or overweight. So I hope I convinced you with this data that among the lean patient, NGS-MRD still had an effect. With NGS-MRD positive, patients had poor event-free survival, and the same was observed with obese and overweight patients who were being NGS-MRD positive as further reduction in survival. And obese overweight patients who were pre-transplant MRD negative had survival closer to lean MRD positive patients. Therefore, we observed a decreased event-free survival by weight category and NGS-MRD status. That took us to the next trial that's happening at the current time, which we called INDRAD. And basically, the central hypothesis for this trial is pre-transplant NGS-MRD negative B precursor ALL patient treated with the study non-TBI regimen will have less than 10% relapse rate and more than 75% overall survival. In another way, we're asking the question, could we avoid the TBI and maintain the same excellent outcome in the NGS-MRD negative patient? And this is an ongoing trial. Hopefully, we'll have some preliminary results to report on in the next year. I'm not going to go into this in details, but a common question that and my colleague have addressed that elegantly in the first presentation: what is the role of transplantation in the era of CAR T-cell therapy? And to summarize the slide, if you are using CAR T-cell that use CD28 as a co-stimulatory molecule, like the NIH construct or the KITE construct, those constructs do not persist, and it's known that this is not a terminal treatment, and all of those patients should proceed or should be offered at least transplantation after being in an MRD negative remission following CAR T-cell therapy, and this is depicted clearly here in the data from the NCI. Looking at the data from Seattle for patients who are treated with a CD19 CAR T-cells that uses the 1BBZ ligand as a co-stimulatory molecule and is associated with prolonged persistence, clearly there is a trend toward improved leukemia-free survival if you receive transplantation following CAR T-cell therapy, if this was your first transplantation. So at least based on this data, patients who get transplantation after CAR T-cell therapy with this type of construct or 1BBZ ligand, long-lasting or persistent construct, could benefit from consolidation with transplantation, but this has to be your first transplantation. Follow up to this data, if the patient got CAR T-cell therapy after relapse from the first transplantation, at least based on the limited data, there was no benefit from transplantation or doing a second transplant. However, patient who had short-lived duration of B-cell aplasia, and that's defined as re-emergence of B-cells or loss of B-cell aplasia in less than 63 days after the infusion of CAR T-cells, all of those patients would ultimately need transplantation. So the general feel, if you have persistence of CAR T-cells less than 63 days, all of those patients are usually recommended to transplantation. And as I say, this is all preliminary data since we don't really have a very wide set of data to address this. The final slide that I wanted to talk about is the molecular detection of NGS-MRD after CAR T-cell therapy. And this is from the Eliana trial and was presented in ASH 2018, where basically NGS-MRD was evaluated at day 28 marrow after CAR T-cell infusion, and clearly you could see if you were NGS-MRD negative at day 28 following CAR T-cell infusion, basically you have a much higher chance of longer probability of survival or event-free survival compared to patients who are NGS-MRD negative at day 28. While this is still preliminary, this is underscore the value or the importance of measuring NGS or MRD even after CAR T-cell therapy. In summary, I hope I convinced you that NGS-MRD is highly predictive of event-free survival regardless of the conditioning regimen or graft TCR alpha beta depletion. NGS-MRD improves predictive power for MRD positivity compared to flow cytometry. NGS-MRD identify arrangements suitable for MRD tracking in all BALL and most of DALL patients. In bone marrow, NGS-MRD negative patients, relapse is exceptionally low, which was 0% in this cohort. There was no benefit of GVHD in NGS-MRD negative patient. TCR alpha beta haplotransplants have similar outcomes to other stem cell sources with decreased severe graft versus host disease. And then there is a decreased event-free survival by weight category and NGS-MRD, where lean patients had better survival than obese overweight patients, but among lean patients, NGS-MRD positive patients had poorer event-free survival. And then I discussed briefly the role of transplantation in the CAR T-cell therapy era. And with this, I would like to acknowledge my other collaborators and researchers. This was a multi-center trial where basically there are multiple centers who contributed and helped generating this data. And also I would like to acknowledge the funding sources and the PBMTC for basically being the coordinating center for this trial. And with this, I would conclude if there's any questions.
Is there any questions from the floor? If no, so Dr. Hisham, I just didn't get how could you get the genetic abnormalities by NGS that you will follow as an MRD, because with NGS you can have a lot of data, you can have a lot of ambiguity. How could you depend on this NGS?
So basically you need to have a baseline blast sample, and that baseline blast sample would require to have at least more than 10% blast, and you will have to find a dominant clone that's representing 95% dominance among the other clones that exist into the sample. So basically with the NGS-MRD, you don't have to have a specific clonotypic probes, and you basically do extract the whole.
You just to be sure that I got it right, you just choose the most prominent of them.
Correct. The most dominant one, most prominent one, because that what represents usually the clone that drives the leukemia, and that's the one that's usually you are able to detect.
But you know that sometimes there are microclones that maybe even in normal cytogenetics or molecular abnormalities that can dominate later on, even at time of relapse. So you will take decision based on NGS that no, I will move this patient to transplant, I can omit TBI. Is it? I don't know, did anyone reproduce data similar to this?
I didn't want to go into the test in details, but you are absolutely correct. You can identify more than one clone, and sometimes you could even do tracking with more than one clone. You just choose the most predominant one, but if you lose that one, sometimes you are able to follow the other clones that were existing in the blast sample and subsequent samples. Whether about the reproducibility, actually recently, about 3 months ago, this is an FDA approved test. So it's actually CAP and CLIA certified test that has been highly reproducible in different labs. And now
I don't know, I don't mean the test. I mean decisions based on this test. Is it reproducible? Because I just heard about it from you, which is very interesting.
Usually it's reproducible in about 95% of cases. If you are in about 5% of cases, there is no dominant or informative clone that you could follow through the various phases of transplantation. But you would be able to identify this up front when you do the base analysis of the baseline blood sample.
Thank you, Dr. Hisham, for the presentation. I just would like to ask about the part of the relation between BMI and the response of the benefit survival. There is a lot of literature about the correlation between BMI and the response to chemotherapy in general for previous studies, early literature, for several attributed for several factors related to chemotherapy, pharmacokinetics, and other factors. But how can you relate this to the era of CAR T cell and stem cell transplant?
We published a paper in Blood in 2015 looking into the outcomes based on flow in patients who are diagnosed with B precursor ALL and treated with chemotherapy, not involving transplant at all. And we have shown mostly the same results. However, we could not identify whether in the lab or in animal models why exactly the patients who are obese have inferior prognosis. There are theories about that, whether there is a material that's secreted from the adipose tissue that basically promotes leukemic growth, or the adipose tissue provide a protective niche to the leukemia cells. When you apply that to the transplant, there is one additional explanation other than those two explanations. Usually we do adjust the dose of the conditioning regimen to an adjusted ideal body weight or ideal body surface area for patients who are obese or overweight, which sometimes lead to underdosing those patients, which could be also a contributing factor. This is number one. Number two, usually the performance status and the ability of obese patients to tolerate high-dose chemotherapy is less, so their chances for having complication or transplant-related morbidity and mortality is significantly higher, which could be another confounding factor.
But there are no genetic or molecular differences between those with a higher body mass index compared to the lean body weight? Nobody looked into this?
To my knowledge, there hasn't been anything published into this. We tried to do this in our initial paper post standard leukemia chemotherapy without transplant, and we could not really pin a specific cytogenetic abnormalities or molecular abnormalities in the cohort, which I think it was about 170 patients. We could not really pin a specific one, but it's conceivable on a larger data set that a molecular abnormality could be identified, but none at the current time to my knowledge.
Thank you.
See, we don't have any more questions. Thank you, Dr. Abdel-Azim, and thank you to the speakers and attendees for their attention and for surviving to the end of the session. Thank you so much.